Recently, a second JAK2 inhibitor, Fedratinib, was approved by the FDA based on 2 trials, the JAKARTA, that was upfront study, and there is the JAKARTA 2 that looked at patients after ruxolitinib failure. In the JAKARTA 1 study, patients were intermediate 2 or high risk, randomized between Fedratinib at 2 different dose levels versus placebo, and this led to the approval of the drug in this population. Fedratinib has a little bit different profile. It's a JAK2 FLT3 inhibitor. The toxicity profile is a little bit different from ruxolitinib. When we look at the response rate in those patients treated with the Fedratinib at the 400 milligram level, 36% of those patients achieved the primary endpoint, which is the 35% reduction in spleen volume from baseline at 24 weeks. And when you look at those patients that had platelets between 50 to 100, the response rates were similar, around 36%, and around 1/3 of the patients had symptom improvement. So what to expect in terms of side effects? Because of the FLT3 inhibition, we do observe more GI toxicity. So those patients will have diarrhea, some nausea, and vomiting. That's typically manageable in most of the patients. The rate of anemia and thrombocytopenia, when you look at the numbers, they look equivalent or similar to ruxolitinib. However, one has to keep in mind that the study allowed patients below platelets of 100 and more cytopenia. So probably there is little bit cytopenia observed with Fedratinib compared to ruxolitinib in those patients. The Fedratinib has a black box warning of Wernicke encephalopathy. Originally, obviously, this was a larger concern. However, over meticulous review of those cases, it turned out that probably only handful, 3 cases or so, were true Wernicke encephalopathy. In many cases, this had been linked to thiamine deficiency, patients having nausea and vomiting, getting dehydrated and malnourished. So typically now, obviously, we do check baseline thiamine level in many of those patients, in all of those patients, and we will consider thiamine replacement prior to starting Fedratinib. It is an option definitely for patients that may have borderline cytopenias to consider in the upfront, and it's an option for patients after ruxolitinib failure.